ran a little late and we want to make sure that we keep on time. So I'm Marianne Hopkins, one of the moderators. I'm from NYU.
Jeremy Warren from Greenville, South Carolina, your other moderator, and many speakers here. Go ahead.
Perfect. And we'll introduce the first speaker, which will be Desmond Hunt. And he will be our first speaker. And he is from Cedars-Sinai Medical Center.
Right.
We will hold questions till the end of the session if there's time.
Perfect. All right. Thank you, everybody. My name is Desmond from Cedars-Sinai, and today I will be talking about why we don't have higher quality data in hernia surgery and some of the barriers in obtaining higher quality research in the field. And I'd like to thank the Society for the opportunity to present today. I have no disclosures. So I think it's something that we all kind of intuitively know that there may be a lack of quality evidence in the field, but I wanted to kind of test this premise. So went through the international guidelines using inguinal and umbilical international guidelines as test cases to see what the level of evidence in the field is. And as you can see, it's kind of all what we feel. There's not a whole lot of level A evidence out there, and the strength of the recommendations that are being made is relatively weak. So most of what we know and what we do is based on expert consensus. So why is it the case? When we look for the reason for this, it's kind of just an unfortunate intrinsic issue with some of the hernia-specific metrics that we aim to capture when we're doing research. It's probably a good thing for the patients, but when we look at metrics like recurrence, morbidity that surround hernia repair, these rates are relatively low, but that does propose a statistical challenge for us as researchers. It's just an unfortunate function of statistics that as the event rate for anything goes lower, you have to have a higher power and a higher sample size to achieve adequate power. You can kind of see this concept graphically represented. This is the minimum detectable odds ratio on the y-axis of a given study versus the sample size in your study. And then the different curves by color are the base event rate of whatever you're trying to look at. And you can see that as your base event rate goes down, the number of patients you need to detect the same odds ratio goes up. So if you're looking at a 1.8 odds ratio for something that happens 5% of the time, you're going to need twice as many patients as something that happens in 10% incidence. And we know that unfortunately, a lot of the hernia-specific outcomes do occur in this ballpark, sometimes in the single digits, sometimes even lower. And this is certainly true for recurrence, which is the first hernia-specific outcome we'll talk about. The rate in inguinal hernias is relatively low, so it's certainly vulnerable to these sample size issues that we just talked about. The case might be a little different for ventral hernias, depending on who you read. The recurrence rate is somewhere between 14 and some studies even report 50% overall. And so you would think it'd be relatively easy to detect differences statistically, but then this brings up another challenge, and that's one of a delayed presentation of these complications we're trying to measure. If you look at these curves from two large studies looking at the presentation of recurrences in ventral hernia and inguinal hernia, you see that over 50% of the recurrences don't show up for more than a year afterwards. This may be outside the study period of many studies looking at this outcome, and many are not going to be going out the 10 years needed to see 100% of these recurrences that are going to happen. And the same concept is true with morbidity. Overall, the rate of adverse events after hernia surgery is relatively low, as you can see in the fraction of percents over there. And again, some of the hernia-specific complications we like to look at, mesh infection, mesh erosion, might not present till months after surgery, and so still require a relatively long follow-up period. So I'm just going to briefly touch on patient-reported outcome metrics, which have become a mainstay of hernia research as a quality of life operation. These solve some of the problems that we've talked about so far by being a standardized scale, and they can be collected at any time after surgery, but they still may be vulnerable to follow-up issues. Again, the patient experience may change depending on when patients are reporting in, and so may be vulnerable to follow-up problems. There are many different PROM systems, and there's many nuances to using all of them. I think Dr. Fisher is going to talk about them more in depth shortly. So based on these, we have two kind of big challenges to produce high quality data in the field. We need studies that have a large sample size, and we need long follow-up. And both of these concepts need to be kept in mind when performing studies, especially talking about RCTs versus registries. Of course, RCTs are going to have the highest control of the study and deliver the highest quality data, but because of these two problems, they're going to be very labor intensive and expensive. Registries solve some of the sample size issues, but again, there are some practical roadblocks to what can realistically be collected, and there can always be data quality control issues at that scale. So in addition to these two big barriers with sample size and follow-up, I wanted to just touch on one last barrier, and it's kind of has to do with the kinds of questions that we ask in hernia research and some of the constraints created by the heterogeneity in hernia practice. So just using ventral hernia recurrence as an example, in general, some of the best data we have for this topic demonstrates the importance of kind of broad changes in approach. So that's to say the use of mesh, the position of mesh, pre-optimization of the patients. And these are impactful parameters, certainly, and we feel pretty confident about them, and we feel that they're quite important, probably because they're the best studied, and in some ways because they're easily studied. A lot of this information is available on a large scale in big data. But do these broad changes alone explain kind of the phenomenon that we're seeing? And certainly in ventral hernia, if we're really having such a large recurrent rate overall, are there other factors that we're not measuring that are being overlooked in addition to these factors? And ultimately, some of these things may come down to variability in practice or technical idiosyncrasies that are happening in the operating room. These are things that might be described as in the usual fashion, but actually vary significantly from surgeon to surgeon. Such as closure technique, sac management, and management of abdominal tension. And right now, there's not really a codified way to look at these technical idiosyncrasies or surgeon preferences in hernia. Here's a study just out of Stanford that tried to do something like that for anerotomy closure. And they kind of broke down anerotomy closure into these little these microsurgeon preferences, and tried to see what the impact of those decisions were in the real world. And they found that each little decision like that maybe isn't normally captured actually had a big effect. So, I think the question is, can we do something similar with hernia? Can we break down the technical idiosyncrasies and surgeon preferences and maybe give us another avenue of explanatory variables to look at in hernia? So I would say that in addition to the extended follow-up question, the need for a large sample size, another challenge is to characterize the heterogeneous practices in hernia. So in conclusion, we have some significant challenges as we go forward to try to deliver high quality research. And in the following talks, I think we'll be talking about how to overcome some of these. Thank you.
All right, next up is Clayton Petro from the Cleveland Clinic Foundation.
Hey, everybody. Thank you so much for the opportunity to present. All right, I only got 7 minutes. I'm going to try to go through some of this relatively quickly. Oop, that's not my first slide. Maybe go back. Okay, there's my disclosures. Oh, maybe. There we go. Okay, so if you go to hcup.gov, there's a comprehensive list of systems that you can use to track your outcomes. Most of them we're familiar with, like nationwide inpatient sample, NISQIP. The biggest limitation of these is that they cost money, for one, and that really important for our field is the collection of really granular operative details that aren't always reliable in those databases. So hernia dimensions, mesh size, plane, fixation, those are the types of things that we need to risk stratify our patients and really dig into the details, and those databases often don't provide that. A lot of times we get asked, well, why can't my EMR do this? Can't we use natural language processing or AI? And if information isn't put into the EMR consistently or in a format that can be extrapolated, then that's not always reliable. We looked at something as simple as, reported bile spillage during cholecystectomy, and on a manual chart review for the same group of patients, we found reported in the EMR 15% of the time. Natural language processing was only able to capture that 12% of the time, when in reality, the rate was 24% when you asked the surgeon in a registry, yes or no, did you spill bile? And so, if it's not in the EMR, no form of AI can extract it for you. So why are the op details important? So if I handed you your ACH-QC outcomes. Someone has to be in the bottom quartile, right? For whatever the outcome of interest may be, whether it's opioid consumption or surgical site morbidity. And I think surgeons are really good when you give, for specific patients by the trauma bonding that we all went through for M&M, we understand to take accountability in the specific context of a specific patient. But in the kind of broader, more abstract context of when you're handed a report and it shows that your outcomes might not be as good compared to your peers as you think they are, this is when all the excuses come out. My patients are more complex. I do all the cases no one else wants to do. They are more comorbidities. The hernias are bigger. All the op details weren't adjusted for. And so that's why it's so important for you to be the one to be entering the details of the operation and to have accurate patient-entered data. And for us, we use the ACH QC for that so that you have real outcomes. There's no excuses. You have the ability to compare to your peers, adjusting for all the things that we just talked about, and you have the ability to improve. And once you track your outcomes, really the doors are open for all of these things: quality improvement, risk stratification, trial participation. I'll talk about in a moment, but you can, once you've entered 25 cases in the ACH QC with follow-up, you have access to the whole database. You can query whatever it is that you want to query and ask the question and get the data back yourself. And you can collaborate with others as well. I've been really fortunate the last 7 years to be part of this group, and we have leveraged the ACH QC to do randomized controlled trials. And the reason that we're able to do this is that we're doing, by virtue of putting the data in the registry, we're doing 90% of the work that you would do for an RCT anyway. So the things that you would have a research nurse, that you're paying a research nurse to go around and collect and put into REDCap, the patient care, the demographics, the comorbidities, the operative details. If you're just doing all that as a part of your routine practice and you're routinely collecting PROs, then all you have to do is consent the patient for a trial, randomize, and everything else is autopilot. Most of the things that we do are standard of care type things: standard patient follow-up, standard CT scans at 1 year. So if all that is standard of care, most of those trials that I just showed, we did with zero funding, not a dime of funding. We do have, in full transparency, we have residents that we're able to help, research residents, and we do fortunately have funding for them. But there's no extra funding. It's not like we're getting NIH grants to do all this stuff. We do not talk about research with, outside of our group. So the first rule about research is don't talk about research. So, and the reason, if I'm going to say one thing today, whether it's the ACH QC or whether you use some other platform, you have your own Excel file that you're going to capture all your data in. When you talk to the secretaries up front, to the MAs, to the nurses, whoever's collecting the data, you do not differentiate, oh, this is a research patient and this is not a research patient. Everyone's data gets collected. As soon as it turns into, well, is that a research patient or is that not a research patient? Things are going to get missing. Every single patient you collect the data on, and then the research will come. And I think this is a really important point. These are 3 private practice surgeons that we have collaborated with for our randomized controlled trials. They are private practice, and when we went to them, we didn't go to them because they're at some big academic institution. We went to them because they religiously put their data in the database. They put the data in the database, they collect the PROs, they are OCD about it. So of course, when we all, again, now that we get there, we take all the ownership of getting them through the IRB, whatever DUA process has to occur. And then they call us for randomization. They consent their patients. And boom, they're in a randomized controlled trial. They are 2 of our lead enrollers right now for our opioids trial for inguinal hernia repair, which is 5 tablets versus 0 tablets. And to address, this is a 900 patient RCT. If we were to do this just at the Cleveland Clinic, it would take 5-6 years. Now that we've partnered with these private practice guys, we're looking at 2 or 3 years. So to answer for some of these questions we're getting into, where it's huge groups of patients, this is the solution. Todd Harris has even, leveraged this, on some of his marketing. He's a private practice surgeon, so he has been able to show that his outcomes compared to his peers are better, and he uses this to market himself as well. So what about long-term follow-up? Anytime anyone talks about the QC, the biggest question we get is, yeah, but you guys are really good at 30-day follow-up, but not good at long-term follow-up. Well, just like every other database, NIS, NISQUIP. And so, we have now switched platforms, and we can talk more about this later. But we've switched platforms from Arbormetrics to OBIRD. And the reason we did that is all the things that it brings to the table in terms of patient tracking. And so, they have the ability to collect PROs live through their apps. They have the ability to use the apps on wearables so that you can monitor your patient's recovery, obviously with their permission. And so that by the time they see you at their follow-up appointment, you have a great idea what their recovery has been like since they've been at home. when you get follow-up emails, I think a big issue is that a lot of our emails for follow-up look like, it could be spam and they don't know whether to trust it or not. These come from a marketing perspective with your picture, knowing that this email is coming from your surgeon, and you want to know what the outcomes are. You want to know what the patient-reported outcomes are. And so in an ideal world, we're looking at a situation where you can query the database for patients, for instance, who feel a bulge a year after the inguinal hernia repair, and have a system set up to get those patients in to make sure they don't actually have a recurrence. And so when I asked Ben, I said, what's the plan for getting long-term follow-up in the QC? He says, it's like a, what is this, a Hydra? He's like, oh, it's like a Hydra. Like I was supposed to just know what that was. And he's like, and so, yep, I'll be done in 2 seconds. I'm probably sorry. So yeah, these are all the different things. EMR integration is also coming down the pike, the ability of the database to couple with the EMR to get follow-up. And so, in the future, I think that, long-term follow-up is going to get a lot easier. If, tracking your outcomes does take commitment by the surgeon, and the ACH QC provides a great platform for that. Thank you.
Thank you for that great talk. Our next speaker will be Monica Poltz, and she's from the Baptist Health, South Florida. Yeah, great, thanks.
All right. I'd like to take a minute to thank the AHS for the invitation to present this talk on collaborative research and really a call to collaborative research. So the goal of this talk will be to define what is collaborative research, why do we need it, and how do we do it? My first true exposure to collaborative research was working on this device right here during my training at Vanderbilt. I took 2 years to do a master's in biomedical engineering working on this device. It has a little piezoelectric sensor, which when applied to the venous plexus over the wrist, can detect the peripheral venous waveform and estimate volume status. And as you can imagine, there's a number of potential applications for a device like this, and multiple specialties were sitting at the table together, fine-tuning and testing this device, including experts in cardiology, anesthesiology, surgery across multiple institutions. It was really kind of a beautiful thing. I was then fortunate to complete my final year of training at Carolina's Medical Center with mentors who have a very successful research program, both in terms of research productivity, but also, more importantly, conducting research that focused on quality improvement and led to many practice changes that improved patient care. This is a slide that I borrowed from Greg Scarla that he presented at EHS last year, where he sort of went through the components of a successful research group. And some of these include obviously physician and subject matter experts. You do need to have a high enough patient volume to be able to make sound conclusions. There's a number of costs associated with conducting research, and the operational aspects of research and funding is required to cover those costs. And collaboration can really help with all of the above. So the Hernia Center at Carolina's Medical Center really embodied a multidisciplinary and comprehensive approach to taking care of complex hernia patients, multiple specialties working hand in hand to provide great clinical care, and also with regards to research. So collaborations with other specialties such as radiologists looking at Botox injections prior to surgery, or infectious disease physicians looking at optimizing perioperative antibiotic protocols, improved patient care. And one of my favorite collaborations, Dr. Henneford showed these slides in his presentation in the last session, but one of the factors that they identified as independent predictor of increased length of stay after hernia repair is age. And we often think of age as a non-modifiable risk factor, but when a comprehensive geriatrics program was incorporated in the pre- and post-operative setting, it was able to reduce length of stay and ICU admissions. So these are some great examples of multidisciplinary collaborations within an institution, but there are multiple types of collaboration that can be beneficial to research, especially with regard to hernia. So there are external collaborations, multi-institutional collaborations that can increase the volume and efficiency of data acquisition. Societal collaborations is what we're doing here today, right? The AHS provides us a forum to share our ideas and present our research, to meet each other and form friendships that lead to collaborations and opportunities for grant funding. And industry is another important collaboration in the field of hernia research, and can provide an avenue for obtaining funding. So we'll talk a little bit about multi-institutional collaborations. The easiest way to build multi-institutional collaborations is probably through participation in the multi-institutional data registries. And Dr. Petro just talked about the ACHQC, which is relatively simple and free to join and offers a variety of I'm blanking on the word, but for surgeons who are involved, including statistical support for data analysis, the ability to participate in embedded multi-institutional trials. The data is surgeon collected, and so the completeness of the data does depend on participation from the hospitals and surgeons. The International Hernia Mesh Registry is a patient-reported outcomes global database that incorporates various outcomes related to mesh use. The Michigan Quality Collaborative is a statewide initiative that actually employs the use of data abstractors to help abstract the data. Hernias is a surgeon collaborative that's in development with a focus towards gender-specific outcomes after hernia surgery and supporting women surgeons. The Danish Hernia Registry, there's a number of strong, large databases in Europe that have been very productive. And the Danish Hernia Registry is actually a national registry that's mandated, so captures all the hernia repairs that are performed in the country. And then there's collaborations within societies. So again, societies such as the AHS, EHS, SAGES that provides this opportunity for us to share our research, to meet each other, to form friendships, to form collaborations, grant opportunities. There's a variety of initiatives to form research networks. Inter-society collaborations have led to important work and development of guidelines, the ability to participate in committees. And industry is another important aspect of collaboration in hernia research. So most clinical trials at even specialty designated or self-designated hernia centers are industry sponsored. There are two types of grants broadly that can be sought from industry. One would be an educational grant that can fund things like conferences and courses and lectures. And then there are grants that can be applied for investigator-sponsored studies. It's important, obviously, to be mindful of potential conflicts of interest in industry-sponsored studies and making sure that there is accurate and non-biased reporting of the data. And last but not least, the most important collaborator is the patient. If you've heard John Fisher, and he'll probably talk about this today, discuss how they developed their patient-reported outcomes metric, it's really pretty inspiring. And it seems obvious that we should be directly soliciting from patients. We think we know what outcomes are important to them, but do we really, and how often are we actually asking them? And directly soliciting their feedback is important. The ACHQC also has initiatives to engage patients, and it's a step in the right direction. I'll skip these slides just for the sake of time, but there have been a number of demonstrated benefits of collaborative research, both in terms of research productivity and number of publications, even when controlling for the number of co-authors. And in surgical research, positive correlations have been identified between the number of external collaborations and academic output, journal diversity, and journal impact. So broadly, there are a number of benefits to collaborative research. One, improving our research impact and productivity, allowing avenues for funding, improving our external validity of our results through multi-institutional collaborations, quality control and efficiency, helping provide the infrastructure for less experienced programs, and allowing us to share our experiences and new ideas. This is a slide that I like to include from a text in 1876 describing invagination and ligature technique for hernia repair, which was described as sort of a one-size-fits-all, the way to repair any hernia. And at the time, they felt that this was the best method that will ever be described, and there's no further research to be done. And we know that this isn't true, and the amount of research that's being performed in ventral hernia repair is increasing at an almost exponential rate, and collaborations are only going to help move things forward and better the care for our patients. Thank you.
Thank you very much, Monica. Next up is Dr. Ben Paulus from just Ohio State.
Okay. Take it. You do not know what a hydra is. So thanks, everybody. Thanks, Dr. Hopkins, Dr. Warren, for the invitation, and I appreciate the opportunity afforded by the AHS to talk about this. about funding opportunities and partnerships with multiple organizations and industry for research and keys to success. I'm going to gear this really to the trainees and the junior faculty in the audience. I wish someone had had this discussion when I was at that stage, because I think there's certain paths you got to take to be successful here. These are my disclosures. So if you kind of look at the common sources of research funding, and number one, to do meaningful research, you're going to need some money. The interesting thing is that the most things that we publish in peer review articles, about 98% of it is not funded, and only a small proportion is funded. I think this is where we can have a lot of impact. Common sources, NIH, other federal dollars here in the United States. The European Union also has a mechanism for this. Foundation, local grants are something that often gets ignored. And then, of course, partnerships with industry. A little word about foundation grants. You can roughly split that up into the typical foundations we know, the Gates Foundation, Wellcome Trust, Herbert Hoover, the society grants as well. And then local grants are often, again, just not really known. State grants. We just received a grant from the state of Ohio for opioid use. So these are things that you can kind of leverage that your state might have access to, and certainly also from your institution. So why would you want to do this? Surgery is busy enough. Number one, to advance our field. I mean, this entire session is how do we increase the science in what we do? And I also think to answer real high impact questions to help patients. If I had to think of really the 5 high impact areas that have been woefully ignored, it's the following. Can hernia repair improve pelvic floor function? Can hernia repair improve pulmonary function? Can abdominal reconstruction improve lower back pain? What happens at the mesh tissue interface long-term for different types of meshes? Can long-term mesh use cause adverse immune system modulation or autoimmune issues? We've been talking too much about how to fix holes. This is the stuff. You can imagine if we're talking to a patient, we can say, yeah, actually we can help your back pain you've had for 6 years because your anterior abdominal wall is unstable, or we can help your pelvic floor dysfunction because your anterior abdominal wall is unstable. That's where I think we need to go. So I'm very proud of this slide because this is my very first AI created figure graph. I literally went to this thing, and this is fake data, by the way, so don't take pictures. I typed into this AI thing and said, produce a graph with 2 axes and this thing here. And this is basically the amount of funding versus the ease of obtaining funding. And you can see that those different buckets have different amounts associated with them, and they're inversely proportional to the ease of obtaining that money. So basically, NIH grants, yeah, higher money, but very hard to obtain. On the other side, our relationships with industry, a little bit easier to obtain, but it tends to be in less amounts. And again, my first AI-generated figure, thank you. So also considering which group to engage is important. This is really dependent upon your time available, the infrastructure available to you. And there's this concept of covering what are indirect and direct costs and making sure in your granting applications you include the funding for both of those things. Because you want money ultimately not just to keep the lights on, but actually do the research. And then, of course, the prestige involved with different sources of funding and the impact on promotions, that sort of thing. So what does federal funding look like? So we received this grant from the NIDDK looking at abdominal core rehabilitation to improve outcomes after ventral hernia repair using physical therapy, actually. And we used a concept called a multi-PI system where we're not just co-investigators, but equal investigators with our physical therapy colleagues. And this is the group that helped put this together, a really talented group of physical therapists, biostatisticians, and our own staff. One concept that really kind of was brought out to me that I didn't understand was you have to have a really good conceptual model to put one of these grants together. And that's where these collaborators really, I mean, we're surgeons, we don't know about conceptual models, but there are people who know about this that you can collaborate with. What does foundation funding look like? This is something that we just received a word for funding for. This is a study we just submitted to the Herbert Hoover Foundation. These are the people who make the vacuum cleaners. Apparently, they don't like plastics. So we found that out, and we put this together and got some funding from them. The hypothesis here was implantation and degradation of mesh plastics leads to detrimental inflammatory responses, a known precursor for cancer. We're just learning that there may be a small link there. So we got some money for that. This is our team for that. We have 2 BME and nanotechnologists and material scientists, someone who's an expert in lipidomics and metabolomics. And then the guy in the bottom right is a collaborator from Arizona State University. He's an expert in environmental plastics exposure. So we put this team together to kind of answer these critical questions. So this is what we're also doing with part of this grant. We're going to create a mesh biorepository that's linked to the ACHQC. So in addition to having the clinical data, we're going to actually have tissue data as well to examine these kind of issues. So if you find yourself, you don't have a lot of these folks around, PhDs and folks like that, I think a lot of us turn to industry funding, which provides, honestly, is the engine of what's driven innovation in our field for the past 15, 20 years. This is really built on relationships, and certainly you need to align your research goals with that of the company. They will look at your things that are important to the relationship as a potential receipt of the funding. But the other thing I would advise is, surgeons do this all the time. They go to your local rep and say, hey, I need $250,000 to run a study. How can you guys help me out? That's not how to approach this. It's a much more collaborative relationship building experience. And certainly we have to navigate the COI carefully. So in kind of big buckets, the clinical trials that are traditionally done in industry are contrasted with investigator-sponsored research. And you can see kind of the difference between those two tracks of obtaining funding. One thing to mention, AdvaMed is a clearinghouse group of industry at codes put together to help navigate these relationships. It's important to be aware about this if you're going to head down the industry funding route as well. So where do the funds come from? Different areas within particular groups of companies. This is really important to know, especially as you develop these relationships, where the money is actually coming from within the company. And there's a lot of sources on how to obtain that information. So in summary, the common sources of funding, NIH and other federal mechanisms, foundation, local grants, industry. So in conclusion, I think this can definitely positively impact patients, establish yourself as a credible investigator, certainly build lasting relationships. Some of the most rewarding relationships I've had over my career are those with our industry partners, and it's really been very beneficial to patients as well. Have a good team with clear goals. Really don't give up. Persistence very much pays. You're going to get denied a lot. And then also you need to have a little bit of a salesperson in you because I think that helps as well. Thank you.
Thank you so much. Our next speaker is John Fisher from the University of Pennsylvania.
Good afternoon, everybody. Really a pleasure to be here. I'm going to talk about PROs and their impact on clinical practice and outcomes, a few disclosures, funding from the NIH, a few different consultancies, the cases and the patient pictures I have permission to share with you. Most hernias won't kill you. They'll make you suffer, though. And I think that this really gets at the core of the problem here is that it impacts quality of life in a significant way. When we kind of look at the spectrum of this disease, this is kind of a collage of patients that I've treated over the years. It's a very diverse phenotype. And I think that this really, makes it necessary for us to think carefully about how we're measuring outcomes. I came up with this. There's probably more ways to fix a hernia than 864, but this is kind of what I came up with. So there's very different ways to treat this problem. And so we've got a very diverse spectrum of patients, and we have very heterogeneous ways to treat this problem. I think it really kind of lends itself to measuring quality of life to understand outcomes. And so what I would say, again, to kind of recap, is it's a very diverse discipline with a wide range of approaches in a population of patients with very heterogeneous symptomatology. And I think binary clinical outcomes are frankly not sufficient to measure what we really intend to measure, the effectiveness of our treatment. We're not just patching holes, this has already been said, but I think that abdominal wall reconstruction really represents a reconstructive intervention intended to improve quality of life. Here's a patient. We've all seen this as a pretty routine case. But what's interesting, the figure on the right is what's called a radar plot or a spider plot, and his preoperative quality of life is represented in red and his postoperative quality of life in blue-gray. And what you'll see, smaller scores are worse and bigger scores are actually better. You'll see, and you'll appreciate a multidimensional improvement in quality of life from a single operation. I think this really kind of speaks to the potential impact that our operations can have on patients. And of course, I love his six-pack as a plastic surgeon. Really proud of that, of course. So I guess I would say this to you. A modern hernia operation is not just a repair or patch. It's a functional restoration of the myofascial abdominal wall with the intention of restoring the dynamic function of the abdomen. And this really is reconstructive surgery. So I think that we do have a reconstructive problem. I think we almost have what we need. I think we all have the skill set. We have the reconstructive solutions, but I think we have to be very thoughtful and mindful about measurement. And we have to have a willingness to measure and of course, to follow through. We need to look in the mirror, and I think we recognize that we are quality of life surgeons in many respects. And of course, measurement allows us to intentionally improve what we're doing. So kind of a word about PROs, and just to let you know, the timer is not running, so you've given me carte blanche to talk as long as I would like. So what is a PRO? So a PRO is any report on the status of a patient's health condition that comes directly from the patient without interpretation of the response by a clinician. So that's a PRO. So a PROM, a patient-reported outcome measure, is a tool that quantifies self-reported patient perceptions of health and quality of life. And what we want is a disease-specific instrument, has to be patient-informed, and should be psychometrically validated to really help understand the effect of surgical interventions or, frankly, no intervention. I would think about it like this. All the things that the patient communicates to you, a PROM is like a prism, right? And what that can do is it can transform that information to help elucidate all the things in an objective way that the patient is experiencing. I think additionally, and I'll kind of talk a little bit more about this, it can help us understand if we're kind of achieving alignment in terms of our clinical outcomes, kind of what we're caring about and measuring, and kind of also what the patient cares about. And that ideal improvement, of course, is a big positive patient-reported outcome improvement, but also good clinical outcomes. And I think that we should be striving to be in that green circle. So I think ones and zeros, aren't really enough. This is a very complicated suprapubic defect in a cancer survivor who's had a number of attempts at repair. She had several complications after surgery, and you'd probably grade me as a zero, as a failure, right? She had numerous complications. There she is post-operatively in a pair of jeans, which was really her patient-defined goal. There's the pre and post-operative quality of life measure. I think a really nice representation of kind of what mattered to her and that divergence between clinical outcomes and patient-defined outcomes. Another kind of case example, this is a complex patient on the right who had, I guess, a great outcome. And so clinically fine, but this guy suffers from chronic abdominal wall pain. And so again, having this additional data might create some murky interpretations of kind of were we successful or not. But I think the additional data helps us better understand kind of what's going on in many ways. A very complex patient, octogenarian. I don't like to operate on folks in their 80s, but this lady somehow twisted my arm, has a massive, massive defect. And when you undertake these types of cases, there's a lot of risk involved. And I think it'd be very, very thoughtful. And I think that having that quality of life data in my practice has been very, very useful to understand that some of these chances that we're taking, I think, have a positive impact on patients. And there's her pre and post-operative quality of life. So kind of the data. So what has quality of life, actually taught us? I'm going to start with a paper from our group. These are utility scores. And so kind of where does incisional hernia fall on a spectrum of kind of health condition where, of course, 0 is no quality of life and death, and 100 is perfect health. It's actually right about in the middle, kind of very close to being death. And so, of course, this is a very significant health state for a patient to experience and live without treatment. One of my favorite studies in the published literature on quality of life is by Jorgensen and colleagues, a prospective observational cohort study, which I think beautifully correlates an effective repair with a measurable improvement in core function and an associated improvement in health-related quality of life. Just what Ben was talking about, which I think is absolutely fascinating. And this is really, I think, what we're doing when we take care of these patients. Also been borne out in other studies. This is from Rosen and colleagues. An abdominal wall reconstruction measurably improves physiology, and that translates into a quality of life benefit. This is great work from Henneford's group. Very much so kind of PRO-defined change is a function of their preoperative baseline levels of quality of life and pain. And so I think if we're not measuring pre-op, it becomes very hard to interpret what happens post-operatively. Another example from the literature that I think kind of shine some light on the value of quality of life. This is an article from the clinic, 2 and 5 year composite outcomes on terms of clinically defined and patient-defined recurrence. The recurrence was 31%, composite recurrence at 5 years. But the authors note that, despite recurrence, patients still had improved pain and quality of life. And so again, I think it's providing meaningful information to help us understand the effectiveness of the operations that we're doing. This is maybe one of my favorite studies that kind of illustrates this point, I think, in a very different way. RCT from Mike Lang and colleagues looking at whether or not closing the fascia in the context of a laparoscopic IPOM adds any benefit. Turns out there's no clinical difference, no statistically defined clinical difference. But if you look at the data, they actually captured patient-reported outcomes and showed that in the patients that had their fascia closed, there was improvement in quality of life. And so they kind of, to quote them, note that even though surgical outcomes after repair are of high importance, patient satisfaction and their symptoms continue to be a major driving force for repair, and its improvement should be a priority. This is a paper from our group, and I think that having preoperative quality of life, I think, is so important, because if you look at these patients who have had either no prior hernia repair and get the repair, one prior repair, get a repair, kind of so on and so forth, where they start, I think, has a huge impact on the interpretation of kind of where they end up, simply meaning that those who have had multiple failures in the past start at a lower quality of life, and they probably don't go as high. So that's a relative change in quality of life. And I think it's super important to be able to have that information, to understand where people are starting, and then to kind of look at where they're going, as a function of their operation. Lots of evidence out there. This has already been reviewed and shown. I think what's super cool about these studies that are kind of coming out, a lot of them from Cleveland, is that they're integrating PROs into their studies and their trials, and a couple more here. So our group, just to kind of share this with you, the instrument that I've been referencing is the abdominal hernia Q. It's available, it's open access, and hopefully this QR link works, this code. If you guys want to scan this will take you right to the instruments, the papers associated with it. It's open access. We're using it. It's built into Epic in our group, and we've really found it to be incredibly useful to help us understand what's going on with our patients, and we'll set the stage for lots of future work. If you guys want me to email to you, I'm happy to do that. So to kind of conclude, I have no idea if I've gone over. I would assume I have. Hernia is an incredibly diverse condition. And I think what's important is that there's a tremendous heterogeneity of treatment effect that necessitates multidimensional measurement in this field. PROs capture the patient perspective, add meaningful information to support decision making, and I really do think they complement clinical outcomes, yielding a more complete picture. And lastly, PROs just can help us learn, honestly, be better, add value to the way we take care of patients. I have no idea if I went over. I'm sorry if I did. That's my email. Thanks, guys.
Thank you, John. That was excellent. Next up is Nadia Hendrickson from University of Copenhagen. Welcome. Slight change in topic from the printed program. This will be discussing outcomes in database studies.
Thank you. So here are my disclosures. First of all, I am the Vice President of the Danish Hernia Database, and I do believe in hernia registries. So this talk may be a bit biased in that direction. So when we look into randomized controlled trials versus registries, we do know that it's much more expensive to perform an RCT. And we also know that the external validity of a database study, which shows us real-world data, is much higher than of an RCT. But the internal validity of that little group you study in an RCT is much higher. On the other hand, the risk of bias is higher in the database study because we do not exactly know what is put inside a large registry or database. You have to at least validate what you put inside the registry. Some registries do provide long-term follow-up, and it's easier to follow the patients for a long time. And it can also research rare events. But we do also know this level of evidence according to Oxford. And when we do perform guidelines, we usually only stick to levels of evidence of 1A or 1B. And therefore, all the guidelines that was mentioned in the first talk were of low level of evidence. Because when it comes to hernia research, there are not that many RCTs out there. On the other hand, there are many cohort studies, but usually those are not included in the guidelines, which I do believe is a problem. So advantages of hernia registries are many, but some of them are that we can monitor and improve quality. We can also give feedback to individual surgeons and hospitals, and we can identify trends and outcomes on a national level. So this is an old slide from 2018. Many more hernia registries are out there now, but the Nordic European countries started the hernia registries first in Sweden and then followed Denmark with the Danish hernia database. And in Denmark, it's mandatory to report to the database, meaning that every hernia surgery is reported into the hernia database. And every Danish citizen has a unique identification number, so we can follow the patients until they die or immigrate out of the country. So we do have almost 100% follow-up of every hernia surgery performed in Denmark. So, as I said before, there is a risk of bias in database studies, because if you put garbage data in, you will get garbage data out. You do believe you have the best ever science project, but if you look into the data, you may not have that. So therefore, it's mandatory to validate the data you put inside your registry. So let's have a look at some rare events. If we just look at these two studies from the German hernia registry, where they looked at outcomes after laparoscopic TAP inguinal hernia repair. They concluded that out of 20,000 patients, chronic pain at rest after 1 year was 5%, and they also identified risk factors for chronic pain. And what about seroma rate? It was around 2.2%. So this is the Hernia Research guideline for management of groin hernia repair. And in the updated guideline, it says that a high weight mesh is recommended for a laparoscopic inguinal hernia repair. And that's actually a strong upgraded strength of recommendation. And this recommendation were based on a few RCTs with a few patients. But if we look into recent database studies, we can see here from the Swedish registry, might be difficult to see, but the purple dotted line, it's a low weight mesh fixated with fibrin glue, and it performs just as well as a standard polypropylene mesh. So if you get high volume data, you might see that these are not the same results as you would find in a smaller RCT. In the Danish hernia database, we looked at the same. We took the most used meshes, top 10 meshes used for a TAP inguinal hernia repair, and looked at the recurrence rates, and we could find no differences between low weight mesh or high weight mesh. These are unpublished data. So what about the long-term follow-up? These slides or these figures have been showed before. We do know that the longer we follow the patients, the higher recurrence rates, and therefore this is a strength of a hernia registry compared to an RCT. Another one from the US also saying that the longer you follow the patient, the higher the higher recurrence rate. So after 5 years, a 45% recurrence rate after ventral hernia repair with mesh. Scary results, right? So what about mesh surveillance? These are two studies from the German and the Danish hernia registry, where we found that fissure mesh increased the risk of recurrence, and therefore fissure mesh was withdrawn from the market. And actually, we do collaborative work with the industry in the Danish hernia database. So if a company comes to us wanting some specific data on a mesh product, we will provide them provide it to them, but we will not give them any data on other kinds of mesh. So we always do it, as you see on the right-hand side of the screen. It's one mesh compared to other meshes where we pool the other meshes. We don't give specific data on other meshes to the companies. So also from the ACHQC, also emphasizing how mesh surveillance is important with registry data. So summing up, the power of registries, we can detect low number of events and large sample sizes, and we can provide a long-term follow-up, and they are crucial for mesh surveillance. And I do believe that data from registries should be included in guidelines, but we have to secure a good data input. Thank you.
Thank you. And just a note, the break is after this session, so we'll ask our speakers to stay, and if anybody needs to leave, that's fine, but we will have a couple minutes of questions afterwards. And our final speaker is Kamal Atani from the VA Boston Healthcare System.
Thank you, Dr. Hopkins, Dr. Warren. So I was asked to talk about opinion leaders and evidence, influence, experience, and disclose if you think about clinical practice, a good analogy is a tricycle with a steering big wheel being clinical care, driving research and education. And if you take the big wheel, clinical care, you can think also about three different analogies. In the first one, evidence is steering the tricycle with influence and experience being the helpers in driving the tricycle. And of course, you know, we've heard a lot about evidence from the various speakers. You know, evidence comes in various categories, randomized controlled trials, which really ask very specific questions and look at limited patient populations, have a very high level of quality and evidence. Observational studies can be moderate level quality to low level quality, and anything else is low or very low evidence. So, you know, keep this in mind when we're talking about evidence. And it is very important to realize that when we're talking about high-level evidence, any further research on the specific question in the specific patient population is very unlikely to change the confidence in the estimate of the effect. And when you're talking about moderate evidence, further research is likely to impact the confidence in the estimate of the effect and may change the estimate. This is why in most large observational studies, in the conclusion, most authors will put further research is needed to elucidate the question. Anything else, you know, low or very low, the effect is very uncertain. In the second scenario, you have experience steering the tricycle with evidence and influence guiding the tricycle. This is when you don't have enough evidence and you rely on experience. When you're practicing based on observing, living, and assessing the outcomes, like we've heard from some of the speaker, and the longer the duration of practice and the greater the experience, this is when you become the driver of the tricycle. Experience is highest when applied within one specific area. For example, if you're a robotic ventral hernia expert, you're going to be creating the evidence. Experience in one area is less reliable when applied to a different area. So when you move from robotic colon surgery to robotic ventral hernia surgery, you might not be as good at it. And experience is affected by both evidence and influence. And then in the third scenario, you have influence driving and steering the tricycle with evidence and experience guiding it. Influence is the capacity to have an effect on somebody's technique, practice, management. And it does involve swaying someone to a desired action. And it might be based on some evidence and some experience, or both of them. And its goal is to achieve a good outcome. And evidence and influence is achieved through publications, presentations at national meetings, courses, or personal communications. Now, influence has to be distinguished from manipulation, and one has to avoid manipulation. And those who use manipulation usually use it for a desired goal. And if you look at influence, it's neutral or positive when it's exercised. Manipulation carries a negative connotation and is used to achieve financial gains, market dominance, and can also result in exploitation. So a lot of time, manipulation is used when industry tries to sway you to use a product with little evidence and exploit you to become a spokesperson for that product. A much better approach is to team up with industry to create evidence for a product, like we've heard from Dr. Poulos, getting some funds from industry to create the evidence. So to conclude, it is, a difficult paradigm, but we all function within evidence, influence, and experience, and each one of those is affecting the other. We cannot just practice based on just evidence, because evidence is not available for everything that we do. We have to rely on some experience, and we have to also listen to what others are doing, their own experience, and how they can influence and teach us within our practice. So my preferred scenario is scenario number one, with the tricycle being driven by evidence. But again, this is not always possible. Thank you for your attention.
Thank you so much. Any questions from the audience?
What we really need is we need really good data. And if you look at the Danish database, you capture 93% or so of the ventral hernias, and you capture it directly from the chart. And then John's got this amazing quality of life summation for patients if they'll answer their emails. And then Ben, you've got this like crazy database with lots and lots and lots of surgeons participating, but most of the data comes from the surgeons themselves. I mean, how do we combine this to actually get great data from the charts, which is objective, get patient data and have patients actually like answer their emails? Because like with you guys, we had the same sort of problem. You get 13% of people when they know they're supposed to answer their emails, answering the emails. So you actually get the data. How do you combine that? So you can actually have yourself we can put you three together, and we're going to have ChatGPT for all together.
Yeah, thanks, Dr. Hannaford. I mean, I think that's the gigantic gorilla in the room. I mean, just the holy grail of what we're trying to do. I think at a very base level, it's going to take some meaningful collaboration and figuring out of creative ways to do each one of those components, just access the patients, get the patients to respond to what we need to respond, or even make it completely automated, take that whole out of the whole equation out of it. As far as follow-up, that's the very difficult challenge that I think all of us face. And I think where, in addition to working together, figuring out ways where we can automate more of this and just remove the manual component is really going to be the key. I also think as a close follow-up to that answer is it's going to require different types of data for different questions. I think all of us in our own areas are trying to be the catch-all for hernia patients, but I think it's going to take different approaches to address different questions.
And can we get the mic? Good. It's coming right behind you.
Can you give it in a second? Testing. I'll just yell. It was great to hear all of different perspectives. I really enjoyed the talks. And one thing I kept thinking about is we do a lot of teaching. I'm in an academic program. We do a lot of journal clubs. And the majority of people aren't here. The majority of people who do hernia research aren't here. And so I wanted to know how important all of you think it is and how to solve the problem of a lot of the data that we're putting out there solves one little answer. And I don't think most people who read research actually know what they're reading or what they're interpreting. So they put something up that says one thing and people interpret that as something else, right? You take the Stitch trial, it's very scripted as to what they did in the Stitch trial, how they measured the length of the suture and how they cleaned off the fascia and everything else. If you just grab a 2.0 and go, see, I'm doing the Stitch trial because I had 2.0, that is not the same, right? And you see that over and over again in all the data that we produce, that people go, oh, yeah, I saw that, chlorhexidine doesn't work, so I threw it out because there was this RC, like these sweeping changes in our practice. So how important is it to get people to understand how to ask a research question, how to answer a research question, and how to interpret data? Because we didn't really talk about that at all. And I got to say, throughout the talks already, not necessarily in here, but in general, they're often even presented wrong by us. It's like, oh, here's this great thing, and this is what it showed. And I'm like, that's not what it showed, right? So it's hard to do, but we don't do that. Like, Ben, I just say, those were great grants. You had huge teams of PhD researchers that spend their lives dedicated to understand research, and you've done that too, but most surgeons don't. So like, how do we get that piece?
And you may want to add, how do you integrate it into your practice if you're
so that
not
we
at a
can
major
spread
academic
that,
center?
right? Because you're doing all this great work. How do people know what they're taking away from it,
I think you volunteered yourself for a panel for next year. It sounds like a great idea.
So I can't answer all of those questions, but I think not everybody needs to know how to design a randomized controlled trial. Not everybody needs to know how to get funding. But in terms of the interpretive piece, I think that's where journal clubs and meetings are really important, because I think that when the data does come out, because we do spend tons of time working towards some of these randomized trials. It takes years to get them to complete, a ton of work to get them to follow up. And I think it's our job to be very clear about what is the specific question that was asked? What are the inclusion criteria? Who does it apply to? And what is the answer we got out of that? And just because the answer may not be what we expected, it doesn't need to lead to sweeping change. It just answers one single question, and it doesn't need to necessarily change your practice, but you should understand what the implications are of that one question that you answered. So that's the role of these conferences and journal clubs.
One very quick comment. Research is the easy part. When you do a high level evidence research and you answer your question, you have the answer. It's not open to interpretation. You've already done the research. The more difficult part is the implementation. And there is a lot that has been written about implementation, and this is a science by itself. How can I convince you that this is high-level evidence and that the research is valid? And how do you implement it within your practice? That's the more difficult part.
And we'll take these as the last two questions.
I just want to say thanks to Ben for now we can blame cancer on mesh too. So I appreciate that. Another long list of complications to add to mesh related. Thank you. My question is simple, but I think it's a difficult one to answer. Can somebody, or maybe the panel, can you tell me what is a successful outcome in a hernia repair? What constitutes that? We always say it's quality of life surgery, but the first thing everyone looks at is recurrence rates. So to me, there's a huge disconnect between what actually matters and what we're reporting and what patients look at and what we look at in the trials. So I don't know if everyone wants to go through it, but I'd like to get a couple of you guys' opinion on what actually matters and what constitutes what we should be reporting in the literature.
Yeah, I'll wait. That's an awesome question. And I think that it depends and is a function of kind of what is talked about, right? What the defined objectives are. And I think if we lose sight of kind of what we talk about preoperatively, kind of what we're planning, and if we don't measure that before and kind of memorialize that before, we kind of don't know where we travel to and we don't know where we go or we went to. I guess my point is right. If we have a very complex hernia and we have a small recurrence or some complication, but the patient's life is transformed as a result of that, I don't know. You tell me, was that a success? I call it a success because you transform the hernia to something that maybe is more fixable or is, can be lived with. And so again, I think it's not clear. And I tried to say that it gets murkier the more information we collect, but I think that we have to collect it nonetheless.
So I think we need to reset our expectations for ourselves and for our patients in terms of how we manage eventual hernia repair specifically. Every bit of evidence is kind of screaming out to us that the longer we look, you're going to see recurrences over time. And considering what John just mentioned, I think we need to be much more in line with how our orthopedic surgeons advise patients for hip replacements and knee replacements. You're going to get a time before failure, 15, 20 years. That's awesome. We have to rethink it later on. We need a strategy of how to approach the patient across their entire lives, not think it's just one and done.
Yeah, I think PROs are going to be the answer because the most interesting thing out of the 1200 TAR paper that we put out was that patients that don't have a recurrence and patients that have a radiographic recurrence, their quality of life is different as you would expect. But what was really interesting is the patients that feel a bulge but don't have a radiographic recurrence, their quality of life was right in the middle. So there is this linear relationship, it seems, from not having a recurrence, feeling a bulge, but not technically having a recurrence versus actually having a radiographic recurrence. And what's nice about having a PRO outcome like that is it's continuous outcome, which is for like research purposes is great.
Thanks. I was just going to say too, it's the PRO, it's that delta, right? The delta in quality of life as a function of time, right? It's the cumulative delta over time, which is an area of some sort. And I think that Ben just hit the nail on the head. It's like, 15 years of great quality of life, I think, is awesome, right? So even if a recurrence happens at the end of that. And so I think that's really it in my mind. Thanks.
Thank you very much for the great session. Ben, in your talk, you mentioned, and Dr. Aitani as well, collaboration with industry. And you very briefly mentioned that there's conflict of interest that needs to be managed. And I wish you talked a little bit more about that because that's something I struggle with. Particularly as hernia surgeons, we deal with the products all the time. And at some point in your life, if you come up and say, well, we should be using mesh, and you have a financial relationship with a mesh producing company, does that really impact our credibility? And how do you guys recommend we manage that?
Yeah, I think up front, most of us would agree that we're influenced by many things, and we're probably more influenced by the things we don't say we're influenced by. And also I'll follow that up by stating that we as a field would not be where we are without our relationships with industry. I mean, period. We don't have hundreds of millions of dollars funded by the NIH, unlike our pediatric colleagues and surgical oncology colleagues. So we have to generate the evidence somehow. I think there is a way of managing that. Certainly some people do that better than others. I think we have to be very transparent and methodical about it. It's easy to sweep things under the rug. And I think, the folks who are known to have high integrity will kind of reveal themselves. But I think we have to be very open about it because it is an extremely important thing. And I think it's important enough for us. That's the only way we can continue having these meaningful relationships is to be transparent about it.
I completely agree with Dr. Poulos. And, the other important component of it is that you remain very neutral and that you disengage yourself from, having a financial relationship with industry. And anytime you're going to engage in a research that involves industry funding, the bias is going to be there. And the rating of the trial is going to go down based on bias. So, but you know, it can remain very high in quality in all other domains. So I don't think you have to be worried about this unless you're truly receiving financial rewards from conducting a study with industry. You know, the best example is to approach industry and say, you know, I would like to study your mesh. This is my proposal, and this is a prospective randomized trial. Would you be willing to fund it? I own the data, I will analyze the data, and I will publish the results without consulting with you. And, you know, of course, they don't always like that, but this is the best way.
Well, with that, I want to thank our panelists for some really phenomenal talks. Everybody presented really beautifully, and thank you to the audience for staying late. Yeah.
It's a little. Sir? Can you, sir?
Oh, sorry.